measurement of 7.4 and the 14 centile, that's good. So that's normal. So, but I already have I think I have a cardiac abnormality to explain why we have a big nuchal. And then I go down on to just confirming. I was doing the legs, so I was doing the leg on that side, and then I update, and then I confirm that I've got a leg on the opposite side. So I just need to confirm that there are two legs. And as I come across, this is the leg, the second leg with the foot. This is the foot and this leg here. This is the lower leg. This is the knee, and then coming up to the femur. So this is confirming both legs, and I save that image. So I've got a split image showing the arms, split image showing the baby's legs. With regard to the brain, it's hard to do a 4-quad, but I will try and do a 4-quad. So we start off on an image at the top. We go to the top left-hand corner, we reduce it. I have augment on. I'm going to increase my acoustic output. And the first image that I get, I see that the calvarium is, well, let me just take the images first. So, let's take this off, then update. Then my cavum balum interpositum. Then my aqueduct of Sylvius. And then my fourth ventricle. Fourth ventricle is hard to see in this baby. And when I'm looking for the fourth ventricle, I look for the choroid lining the roof of the fourth ventricle. That's how I know where the fourth ventricle is, and there's very little fluid in that. And I measure the distance between the posterior border of the aqueduct of Sylvius to the inner border of the occipital bone. And that should be more than 2.5 millimeters. If it's less than 2.5 millimeters, then I think the baby's got spina bifida, but that's normal. And then this is not a good section here because I've got the aqueduct in there. So I've got an oblique section through the head, but that's the cavum balum interpositum. So that's the 1, 2, 3, 4 quad section of the fetal brain, just to exclude that there's not any brain malformation. Okay, and we don't think there's any micronathia. With regard to the orbits of the eyes, I can see that the distances of the orbits of the eyes are okay on each side. I haven't seen a nasal bone. So I've got an increased nuchal translucency, absent nasal bone, and cardiac abnormality. And when I come down to looking at the cord insertion site, I need to make sure there's no omphalocele. Now it's very important, when you're looking for an omphalocele, it's very important that you understand that most omphaloceles occur superiorly at the level of the vein. The arteries are inferior. I know I'm only talking about tiny distances, but it becomes very relevant in terms of trying to work out exactly where that hernia is, particularly in the second trimester. I also record as I go through this in terms of I can see gender, just pass comment on gender if it's in a nice section. The quality of the image is not very good, so what I might do is drop my C2 to 9 and then move to my linear 9 to see if this helps me. But I think I'm probably going to get better images at the vaginal scan. So then I come down to vaginal, and first of all, look at the femurs. I'm getting much better definition of the femurs. And let's see if I get better definition on the heart. Yeah, I do get better definition on the heart too. So just come down to the cord insertion site. So I'm going to go now I'm going to go straight to power. I'm not going to use color for looking at the cord vessels. And I'm going to use power. And when I get to using power, I'll probably get to the point of where I'm using slow flow. So I'm not seeing a bladder in this baby. I know the lipo volume is normal, but that doesn't mean anything to me. So next I'm going to, again, moving on to a slow flow setting, and then going to go into my maps. I'm going to go back to my map of 4. You see the way I'm getting a reverberation artifact, where I'm getting that there's actually 2 on this side. Now, it's possible because it is possible because you can get duplication. You can have 4 vessels in the cord, but mostly when you get something like this, it's artifact. So I just save that as an image. Hope I haven't broken anything. And now you can see that the urinary bladder comes into view. So if you look at this point, so 3 seconds ago there was no urine in the bladder, and now visualizing this point I can see now there's urine.
Excuse me, I take the proposal.
Sorry?
Can I take this?
Yep.
That just for disinfect the transvaginal probe.
Oh, I might kick it over. Do you mind if I just grab it quick, just a little bit of salt?
Yes.
If we come back to this, thanks very much for that, Grace. if we come back to this, looking at the cord vessels to see whether there's duplication of the cord vessels, the best way to look at the cord vessels is not in this position. The best way is to have the spine at 12 o'clock and looking at vertically. But still, the baby's in this position, and now I'll have a look to see whether the cord vessels are. So if you see with slow flow technology, I get much better visualization of the cord vessels. It's very important when you're looking at any structure is to magnify it. Do you see the way I twisted that button? Don't do that. Never, if you can, the only reason you ever twist that button is if you just want on very fine tuning or magnification. So if you ever want to magnify something, hit this button and then HD zoom. Because if you toggle zoom, you lose on the definition. So once I'm in that position, I have the options when I got this power Doppler flow or radiant flow. You also have this option of min, mid, and max. And what this does is it creates a three-dimensional perspective to the vessels. So when you look at the umbilical artery on the right and on the left-hand side, you see that you have perspective on the depth of it. It's a very nice technology, slow flow with radiant max. And it's very nice for looking at cardiac anatomy in the first trimester. So I virtually never use color Doppler in the first trimester. I will use power, and if I get good information with power and a PRF of 25 to 35 centimeters a second, I settle with power. If I'm not getting good images, then I'll go to slow flow. But for most examinations, I use both in the first semester, yeah. Because even if I get nice images with power, I still like to know what else can I see with slow flow, particularly with regard to the pulmonary veins, the subclavian arteries, and that sort of thing. All right, so let's have a look at come around to have a look at the baby's kidneys. So if we come around to the kidneys, I want to know the kidneys normal, so I come across in the coronal section on the kidneys. Now I may not get the details, just straight away when I sweep there, I'm struggling with it and just beginning to get the kidney on the near side. And if you can't get both kidneys in the same view, then split your image. And just going to slightly increase my contrast. Now, I think this here is the kidney on the side, but it may not be. I don't know. And one way of doing it is sometimes just simply putting on your color Doppler and seeing, do you get a renal artery heading out and feeding that kidney? And if you look there now, ignore those vessels. You can see now that is the renal artery going in and supplying that kidney on that side. So I know I have one kidney. And then I can't get around the corner to get the other kidney, so I would need the baby to move into a better position. So that's really as much as I can see just looking at this baby transabdominally, and we might just move to having a look endovaginally. Before I go to looking at endovaginal, I'd like to come back to the heart. So I'm going to change from a routine setting into a first semester cardiac setting. So this here gives you a linear view. You have got the option, if you don't like that, some obstetricians don't like it, you've got the option of going virtual convex, and you may feel that that's easier for you to read. But to me, I'm quite happy with the linear appearance. So when you get that, you see there's a lot of loss of data on that, and you've then got the option of going from Ultra HD to Augment. So I'll probably go to Augment, and that'll just give me a little bit more penetration and definition of what I'm going to see. So then I still see there's still a lot of shadowing on this, but don't give up, because you may well find when you look at this, you will get some more definition when you go to color Doppler examination. When I'm examining, one thing that's very important when I'm examining the chest is every time I'm looking to see, do I have a rib on this side? Do I have a rib on this side? Because if I have 3 ribs on this side and 1 rib on this side, or vice versa, I know that I'm actually oblique. I'm not actually in perfect transverse. So if you want good imaging of the heart, just always be looking at your ribs to see that you've got a full rib, because if you've got a full rib on both sides, you know you're going to be in the right section for looking for a cardiac abnormality. So as I come up now to looking at the color, I'm going to go straight to slow flow, because I don't think power is going to get me there. I'm just going to jump straight to slow flow. And then when I get into slow flow, I'm just going to go back to my map before. I've got my acoustic output at 86%. I'm fine with an acoustic output of 86%. And then I see it's very flashy. There's too much color in there. So I'm going to pull back on my gain on that. And then I'm going to go to my radiant flow, and I'm going to increase my radiant flow from min to max. And then I'm going to toggle zoom, just a small amount of toggle zoom, and then I'm just going to pull back on my gain. I can see the pulmonary veins coming into the left atrium. And then I'm going to say, okay, that didn't really work for me, so I'm going to do something different. I'm going to now increase the power output on it and pull back on the gain. So there's still too much. I want to pull back, keep pulling back, and then I'm going to go to a split image in which I'm showing my 4-chamber view of the heart. See the pulmonary veins entering normal into the left atrium on each side. And I'm getting an impression that there is a 4-chamber with 2 ventricles. And then as I come up, then I'm going to look for this artery that comes out in a boomerang effect that's coming out of this ventricle, which is the anterior ventricle, which is the right ventricle. So this is a typical appearance of a baby with transposition of the great arteries. So then I'm going to save that image, and again save it. I very seldom save images. I save clips, because if I find when the baby comes back at 20 weeks and has an abnormality, they say, well, why didn't you see the abnormality at 12 or 13 weeks? I want to go back. I don't want to look at static images. I want to look at sweeps of things, because that's how I learn. If I miss something, I go back. I will never forget it again. You learn by your mistakes, right? So we save that clip to drive. So when I'm looking at that outflow tract, my question always is where's the pulmonary artery?
Simon,
Oh, stop recording. So yeah. So when I'm looking at the outflow tracts, my question always is okay, where is the pulmonary artery? So if you come inferior to the aorta, your pulmonary artery you should see just here, and you should see it bifurcating. So there's the aorta, just come down below the level of the aorta. And I'm losing detail. I can't say for sure that that's the pulmonary artery bifurcating. I don't know. That's why I need to do a vaginal scan. I need to work it out. The other thing which I can do is I can go from this point in here, go to a full screen on this, clear my text, and then just rotate the transducer and just see, can you on a left ventricular outflow tract view see both arteries coming out in parallel? I'm not getting the definition here, so we'll go to TV.